In the course, and it will be, I think, a long course, we will start with the reticular pattern. The reticular pattern is intimately related to understanding the lung interstitium. I think most of you have this basic knowledge, but in case of someone, this recognition of lung interstitium is new to him. Let's say that the interstitium of the lung, which invests the bronchovascular bundles, starts from the hilum, and here, centrally in the lung, it is called peribronchovascular interstitium around the large artery and bronchus. Then it extends peripherally to reach the smallest unit of the lung that can be visualized in high-resolution CT, which is the secondary pulmonary lobule. When the bronchovascular interstitium reach this secondary pulmonary lobule, it ends into the centrilobular interstitium here. Surrounding the centrilobular interstitium, there are intralobular lines. Intra means within the pulmonary lobule. Between the pulmonary lobules, the structure here is the interlobular septa. So intralobulars are lines, and the interlobular septa, not lines. So this is the correct name. What else? This interstitium extends along the pleural aspect. So this is a subpleural interstitium. Let me accept Dr. Haytham joined. So in literature, and this is one of my favorite books, in the chapter discussing the linear and reticular and fibrotic opacities, this is the title. It's appropriate in textbooks and in academic teaching to explain everything regarding the reticulation, like interlobular septa, which is the main concern here in our reticular pattern. And they include also the fibrotic reticular abnormality, honeycombing, and other linear abnormalities. However, what I want to say, my way is different because I link my way to the clinical. So we'll not talk about the honeycombing. Honeycombing is cysts. So it will be in the fibrotic pattern. And it's not a cyst to be discussed as cystic lung disease. It will be discussed under the topic of fibrosis. So we will understand more when we proceed further. Here, so reticular opacities, in my classification, are interlobular septa. This is the main concern, and belongs to it whenever the interlobular septa is involved, the peribronchovascular interstitium is involved too. But what is observed well in high-resolution CT is the interlobular septa. Retrogradely, you can observe the peribronchovascular interstitium. Beside, we will mention the intralobular lines, parenchymal bands, and subpleural lines at the end of the session. So interlobular septal thickening, called also septal pattern, and they are the septa separating the pulmonary lobules. When they are thickened, they form the shape of the pulmonary lobule of polygonal and polyhedral shape, as you can see here. And what I consider in today's lecture is the interlobular septal thickening, which preserve the shape and size of secondary pulmonary lobules, as you can see here. Now we can see the whole pulmonary lobule, and they are preserved in the shape and size, not distorted by fibrosis. And this will fall under another entity and another topic. So when interlobular septal thickening is relevant, in differential diagnosis. When it is the dominating feature, it is the predominant abnormality in high-resolution CT. And we have to consider these 2 points. The interlobular septa can be normal in normal subjects if they are few and not outlining the whole pulmonary lobule. The second consideration, if they are not the the predominant finding, let me accept the next, sorry for interruption. So I will repeat it again. Interlobular septa is important and relevant for differential diagnosis only if they are isolated finding or the predominant finding. But if they are few and not outlining the whole pulmonary lobule, so this can be a normal finding in normal people. And if the interlobular septa thickened, but we have another findings like consolidation, ground glass opacity, like these findings will change the topic from interlobular septal thickening differential diagnosis into another like ground glass differential diagnosis or consolidation differential diagnosis. As you can see here, we have few interlobular septa here in this. So it's not outlining the whole pulmonary lobule. So this is normal. We can find it in normal subjects. If the interlobular septa is accompanied by pronounced ground glass opacities, so this is the Gracie paving pattern. So interlobular septal thickening here is not to be considered alone. It is part of the whole picture of Gracie paving. So we will have a different differential diagnosis. By the way, it's not specific, the Gracie paving, to pulmonary alveolar proteinosis. It was first described in this disease, but later on, it depends on the acute setting or chronic setting. Our differentials for each is different. Here, I explain in this picture why I don't consider irregular reticulation with distortion of pulmonary lobules as a main topic to discuss under it, the differential diagnosis. Here, what is important in the case is the nodular reticular consolidations, pleural thickening, nodular here, and the patch here subpleural. So these criteria are criteria of pleuroparenchymal fibroelastosis, while the reticulation is a minor finding in the case. So in fibrotic lung disease, irregular reticulation or irregular interlobular septal thickening plays a minor role. When interlobular septa thickening plays a major role if the thickening is smooth or nodular. We will go through this later on. Here, another example of interlobular septal thickening with distortion and change size as shrinkage of the pulmonary lobules with some reticulation. We have also ground glass opacity. We have normal lung here. We have here mosaic attenuation. So we have here 3 density sign. This is more important than irregular reticulation found in the case of hypersensitivity pneumonitis. So before proceeding to the differential diagnosis of interlobular septal thickening and its types, let's be sure that we will not miss it and diagnose it if we have the perilobular pattern, reversed Hello sign, and Gracie paving